Intriguing question for you today, DNA. What good is precision medicine if it isn't being used? We are talking about testing people for mutations in the DPYD gene and how this can prevent unnecessary deaths. DPYD plays a part in how certain chemotherapies are tolerated by patients undergoing cancer treatment. This means that some people with the DPYD mutation may have toxic side effects, including death from a specific chemotherapy called 5FU or capecitabine, which can be given to treat solid tumors such as colon cancer. Our guest, Karen Merritt, lost her mother due to a DPYD mutation that was not tested for prior to starting her cancer treatment. Karen is working with her nonprofit, Advocates for Universal DPD DPYD testing, to raise awareness and educate both patients and physicians on the importance of DPYD testing before chemotherapy. She shares her story and what is needed to try to reduce toxic side effects and preventable deaths. Let's get started. Well, thank you, Karen, so much for joining us today.
My pleasure.
Today, we're talking about something known as DPD, or dihydropyrimidine dehydrogenase deficiency. I hopefully said that right. I practiced. So I wanted to set the stage, but before we get more into technicalities of definitions and explanations, I really wanted you to share your story and why you became an advocate in the DPD space.
So, in 2014, my mom was diagnosed with anal cancer, and the treatment was going to be 2 rounds of 5FU infusions and radiation Monday through Friday. So she had her port installed, and she's such a good spirit. She was more upset about spending the hot summer in Phoenix, Arizona, where her treatment was going to be, than the actual treatment. She was trying to make light of it for the family. So she started her infusion on a Monday, June 9th, 2014. And by the Friday, she, having been a registered nurse, knew that she was dehydrated and need to go get hydration. So she went and got hydration, and there was no at the ER, this could be toxicity to your chemotherapy. And she, was having the beginnings of mouth sores in her mouth. So she gets hydrated, goes home, and several days later, she collapses because at this time she can't eat anything because of the mouth sores in her mouth. They're basically sores from her mouth to her anus. So she was taken by ambulance to the hospital, and the oncologist on call from her clinic says, "Oh, we think this is DPD deficiency, but there was no way we could have known this before we started treatment. Your mother is very sick. She's going to be in the hospital for a few weeks." This is June 19th, and she died on July 2nd, 2014. So what I've learned, this is how I've gotten involved in advocating for pretreatment DPYD testing for all patients who are going to be prescribed 5FU or capecitabine, is you need to be tested for DPD deficiency beforehand. This won't catch all toxicities, but will catch a majority of them. And, we need to save as many people or prevent as many avoidable deaths as possible. So that's how we got a rather rude introduction to DPD deficiency.
And I'm sorry about your mother. I'm sorry this is an introduction probably to DPD that you probably not hadn't had heard of that before.
No, I didn't even know. Thank you. And I did not even know what pharmacogenomics is. I didn't know that your genes could tell that I can't process 5FU chemotherapy, but my neighbor can. I didn't
Mm-hmm.
know that there was variation like this. So that was a whole new world to us.
And you mentioned the 5FU, and I'm going to also try to say this one, fluoropyrimidine based chemotherapy. So it's a chemotherapy for certain cancer types that I guess could be seen as like standard of care. So we see this type of cancer, we're going to offer this 5FU. Why would somebody have this type of chemo? Is it just specific to the cancer type? And how common is it to use this 5FU?
So, fluoropyrimidine chemotherapy, which entails the 5-FU infusion and also capecitabine, which is the oral version, and capecitabine, you take it and your body converts it into 5-FU. And so these chemos are used for solid tumors. It's the mainstay for colorectal cancer, and it works wonders for many people. It's also used, as I said, in solid tumors, so breast, prostate, head and neck, bile duct cancer, and other cancers of the GI tract. So it's a marvelous drug. It's been around since the 60s, the 5-FU infusion part, but 1 in 20 people are DPD deficient.
Okay, that was my next question was, you mentioned with this DPD deficiency that those folks are just not able to have this 5-FU chemotherapy. So tell us a little bit more about DPD or DPYD and what those mean.
So DPYD, as you pronounced it earlier, dihydropyrimidine dehydrogenase, is the gene that tells your body to make the DPD enzyme. And you need this enzyme in your liver to process the excess chemotherapy and get it out of your body. If you have certain variants or changes in your DPYD gene, your body is unable to process that excess chemotherapy out of your body. So it builds up and becomes toxic. And it kills, it interferes with all your red blood cells, your white blood cells, and your bone marrow. So you are set up, in my mom's case, it obliterated her white blood cells and her bone marrow and then left her open to infection. And it turns out then multi organ failure. And what's really upsetting is that these patients, for example, like my mom, her death is not reported to the FDA as an adverse drug event.
Hmm.
On her death certificate, her cardiac arrest, which is the last organ to give out. But the reason it gave out is because of the sepsis, which was caused by the lung infection, which was caused from the toxicity to chemotherapy, number 4 on her death certificate. And what we
Hmm.
know now is we should have fought to change her death certificate to say toxicity to 5-FU chemotherapy, then it would have had to be reported to the FDA. This is my mom's case,
Yeah.
and there have to be other people that have this same reaction. Sometimes patients will have toxicity and they might not get tested for DPD deficiency, but their dose will be lowered. So this is another example of when somebody's having toxicity, but we're not making it aware that the reason that you're having toxicity is because you don't have enough of the enzyme to process it in your body. This is a hereditary condition.
Hmm.
So I inherited DPD deficiency from my mom,
Hmm.
and then I went and tested all of my children. Thankfully, they don't have it should they ever need. But there are other people, another gentleman in our nonprofit, his wife passed away 2 years before my mom, identical story, 5-FU, and their 4 kids all possess the same variant that the wife did. So this is critical information for somebody to have, because as it's been in the past, the oncologist and the FDA labeling has put the onus on the patient to come to you and say, "Oh, I have cancer. This is what you're going to give me, but I'm DPD deficient." So, but now the FDA has updated the labels for capecitabine in 2022 and 5-FU in 2024 to tell clinicians, oncologists, to tell their patients the risks of this chemotherapy if you're DPD deficient, and to discuss testing so that it's a patient choice of what happens. But a lot of clinicians aren't aware of this and they're not
Hmm.
discussing it with their patients. So patients are really not having an informed decision about what the risks of this chemotherapy is to them. And again, this is great chemotherapy for those who aren't EPD deficient. But for the 1 in 20 that are, it could give severe toxicity and even death. And
Hmm.
so patients should be informed and know the risks so that they can make the best choice for themselves.
And like you said, it's not something I think that most people would have heard about. So unless the doctor or the physician tells them about DPD, I don't know how anyone would have heard about it or even know that they have a variant that means that the F5U could be toxic.
Exactly. And a lot of practicing oncologists also could have gone through, they might have had one paragraph about this toxicity in their medical training. And
Mhm.
so, through a citizen petition by the president of our nonprofit, and that in conjunction with an FDA project called Project Renewal, where they're updating the labels of older oncology drugs.
Mhm.
That's how the drug labels were changed in 2022 and 2024. In January of this year, the FDA and the American Association of Cancer Research put on a workshop, DPD, all about DPD, and talking about the risks and weighing the potential harms of testing or not testing. And what came about after that workshop in January is an FDA safety announcement at the end of January. And that was because it became very evident that clinicians are not aware of the updated drug labels to capecitabine and 5-FU. And so the responsibility when those labels changed went from the patient telling the oncologist, I'm DPD deficient, to the oncologist needing to share with the patients that this is the risk and there's testing, and then let the patient decide. If you were told that there's a 1 in 20 chance you could be DPD deficient, and there's this test, and we can tell how this medication will will help you, I have to think that most people would want this test. You can get it for under $500.
Mhm.
And $580 at the Mayo Clinic is your full DPYD gene. For under $300, you can get the Mayo Labs test for 8 variants. So if you're 25 times more likely to have severe toxicity and possibly death because you're DPD deficient, this is a test that I think most cancer patients would want before they have any medicine infused or any pills that they take. And it's a horrific way to die. Once your white blood cells have been obliterated, like my mom, little did we know when she was in the hospital, we were just waiting for her to die. While we were seeing the blood tests every morning and her white blood cell, we were waiting for her white blood cell count to rise.
Right,
But
to come
little did
back.
we know it was never going to come back.
Right. And you mentioned and with your mom afterwards, or I guess while they were trying to figure out what was going on, that they said it looks like DPD. It looks like DPD deficiency. However, we couldn't have known that before the treatment. And I realized it was in 2014. Was genetic testing available at that time?
Yes, genetic testing was available at that time. I, probably was around $1,000. Her hospital stay was a $500,000, all paid
Mm.
for by Medicare. So the economics too of DPYD testing, yes, we're going to save lives, but also from a healthcare standpoint, a $500 genetic test on that one gene, or $500,000 for her 2-week stay in the hospital with round the clock care. I mean, it just seems like it's a no-brainer from my patient advocate standpoint.
You mentioned it was 1 in 20, so that's 5%. That's common. That makes it something much more common than rare.
Yeah.
And people are not necessarily either having the testing or not having the conversation with their physician. Why do you think this is, or why do you think physicians are not having these conversations to offer this type of testing?
I think some of it is lack of awareness. They might not have seen it, or if a patient was toxic or having a bad reaction, they would reduce the dose. And so they never ended up getting testing. The other thing is, we need this to be in national guidelines.
Mhm.
It's standard of care in Europe, it's standard of care in most of Canada. The NCCN, the National Comprehensive Cancer Network, who is really the guidelines body in the United States. And then after them, the American Society of Clinical Oncology has their guidelines. But the NCCN needs to add a recommendation for DPYD testing in all of their cancer protocols that involve these chemotherapy. 5%, you and I don't think is very rare. I think they think that is rare. They have also worried about insurance coverage, but when the guidelines change, the insurance coverage goes up. The other response from the NCCN is they're afraid about the efficacy. If we reduce the dose, are we going to cure the cancer? But there's no efficacy if you give full dose and it's killing the patient, right? So, and there is no scientific evidence that reducing the dose doesn't or negatively affects efficacy.
Hmm. So if somebody were to have this DPD deficiency, they would either just need to know that before electing to proceed with the 5FU. And if they were showing signs of toxicity, it sounds like there would be the option to reduce the dosage or take them off of the chemotherapy.
That's the tricky point, I believe, is the patients need to know beforehand. In my mom's case, once she had her 46-hour infusion, you can't get that out of the body,
Right.
right? And the toxicity for the infusion, you usually it's usually like day 7 to 10, and there came about in 2015. Vistagard was I say a supposed antidote, but you have to give Vistagard within 96 hours at the end of the last dose or the end of the infusion. Most, in my mom's case, that 96 hours that window had passed before
Right.
TPD deficiency. With capecitabine, I think potentially you could stop taking it if you notice signs, but sometimes in other patients in our or other family members in our advocacy group, those patients had capecitabine and had fatal toxicity. So testing up front is way better than playing Russian roulette with your patient's life.
Right. Well, the doing a pre-screen before starting chemotherapy gives you the information that you need to then make some of those decisions. And like you
Correct.
said, then it's not after the fact trying to figure out what's going on and potentially saying it's too late. We've already administered the
Right.
dose.
Right. And so there's are some argument for some patients that they can't, they're like their cancer is so advanced, we have to start like on Monday, like in a couple days. Well, those are emergency cases. I think the normal is you get diagnosed and you have to get a port if you're going to have 5FU. So that's, some time there.
Hmm.
And now the testing results can be back within 3 to 7 days. It used to take 2 weeks or longer.
Right.
So, things are getting better. And the more testing that is done, the quicker the results will come back. And at that FDA workshop in January, there was an oncologist from the Mayo Clinic in Arizona. And when she tests patients, she would use the Mayo Clinic 8 variant panel, which is the one that
Hmm.
I had. And my rare variant was on that panel. But what she's been doing now with patients is using the Mayo Labs full DPYD gene panel, because the Association for Molecular Pathology in August came out with a DPYD recommendation to standardize lab
Right.
panels. And they have 2 tiers of variants. Tier 1 is should have, must have, and tier 2 variants would be nice to have. And so the Mayo Clinic 8 variant panel does not include all of the tier 1 variants. So that's why she is now using the Mayo Labs full gene
Hmm.
panel.
And to give some context for those listening, when we talk about like a full gene sequence, it's basically like you're reading through a document and you're reading every word, almost every letter to see it. If you do something like an 8 variant analysis, you might be taking a book chapter, but you're only looking at every other paragraph or something like that. So it's not giving you that full picture. And what it sounds like is that there's still more that we're learning about DPD. So the full sequencing will give you the best or most amount of information to see if you have one of those variants to be concerned about.
Correct. Correct. And as we're learning more and more, there are some rare variants that are being identified. So, this knowledge about the DPYD gene is growing.
Mm-hmm.
So there will be, as more people are tested, there will be more variants of significance that are caught, because there are some rare cases where somebody will get tested for DPD deficiency, and they, like, say the common 4 or 5 variant panel, and they don't have it, and then they're given 5FU and they pass away. Do a full gene test after death, and they found a rare variant, as in the case of Anil Kapoor in Canada. He was given the 5 variant panel. Oh, not DPD deficient, given the full 5FU, and his story ended up just like my mom's, where the toxicity, and then, you know, died 3 weeks after the infusion began.
And I think that's important to call out to something you had mentioned earlier about the guidelines. So we have NCCN, ASCO are probably some of the bigger ones in the United States when it comes to this is the cancer diagnosis. Here's your protocol. Basically, here's how to treat it. Things to think about. They weigh a few different things, but I remember being a cancer counselor, genetic counselor myself, when BRCA came out, and there was some discussion about it would be helpful to know somebody's BRCA status before treatment because they might decide to undergo like bilateral mastectomy rather than having like a lumpectomy or something like that. So it's more information to help make those decisions. And there was some similar debate back and forth where what's going to happen with insurance or these types of questions. But I think you raise a good point when guidelines make note of a test should be at least offered. That helps with insurance coverage. So I don't know if you could tell us a little bit more about what you're working on with the advocacy efforts and guidelines and trying to get this inclusion into the guidelines. And are there other types or messages of resistance that you've been encountering?
So we've petitioned with our medical advisors have petitioned the NCCN colon, anal, and rectal cancers panel over multiple years, and also one submission to the NCCN breast cancer panel with multiple signers on those letters, and other groups. So over the last 11 years, the NCCN has received almost 10 requests to pre-screen for DPD deficiency, and they have not added it yet. So for patient advocates, we are just outraged by this. This is a patient safety issue, and which is why we became a nonprofit. While we incorporated so that we could have a voice and be able to exhibit at ASCO, American Society of Clinical Oncology, and raise awareness. This is standard of care in Europe.
Mm-hmm.
I mean, in the EU, that is an enormous number of countries, and in the UK, but
Mm-hmm.
yet in the United States, it's not standard of care. And, my mom died almost 11 years ago. This is just outrageous. The National Libraries of Medicine says that 1,300 Americans are dying every year due to DPD deficiency and not screening. That's
Wow.
1,300. That's like 5 jumbo jets crashing. If this were the FAA, they would ground all the planes until they figured it out. So why the United States, ASCO and NCCN have not made this standard of care is just, it's outrageous. 1,300 Americans every year.
Yeah.
That's 13,000 deaths since my mom passed away.
And that I will say, in researching and looking for some of these questions, I was very surprised to see how long testing had been available, the difference that it can make in terms of treatment and avoiding death, right? And reducing morbidity. I am shocked that it hasn't. been updated or changed. It was very surprising for me to learn about this. It was something that I've heard about in my previous careers and thought, oh, this is testing that is probably standard of care. It never once occurred to me that it wouldn't be in guidelines.
Yeah, it is very upsetting. I did learn just last week that Fight CRC, Fight
Hmm.
Colorectal Cancer, they just added, so they, in collaboration with 4R Oncology, they have care sequences. And so Fight CRC has a care sequence for colorectal cancer, and they called out DPYD testing. So, I mean, that's a huge win right there when we've got a huge cancer nonprofit telling patients, like, for patient
Right.
information, you can go on there and say, okay, well, I'm going to, colorectal cancer, and I'm going to have treatment before surgery, and click on that, and it calls out right there, things to be aware of. You're going to get NGS to include DPYD testing. Like, this is amazing. Like, this is going to be educating clinicians and patients.
Yes, I think that's great that they've come through, and I do feel like there's a groundswell or a gathering of momentum over the last month or so. Like I said, as I've been seeing, I know you and your other advocates have been working for a while in this space. Tell me a bit more about your nonprofit. So that's the Advocates for Universal DPD or DPYD testing, correct?
Correct. Yeah, we got a mouthful. We refer to ourselves sometimes as audit, just so we're not saying all of that. So we incorporated about 3 years ago, so that we could attend and have our own booth at ASCO, and that has been wonderful. The first year we were there, we've been twice. We'll be going again this year. The first year we were there, people were kind of like, some oncologists, well, what is this?
Mm-hmm.
Right. And
Right.
then last year when we were there, people are like, oh, can you tell me how do I get this at my cancer center? Or how do I get this in my area? And so those changes have been amazing. And then we get the people that come from other countries, and they're like, I cannot believe this is not standard of care in the United States yet. It's been standard in Europe since 2020.
Mm-hmm.
So that is that raising and talking, and what we like to point out on our website is, the leaders in testing, those institutions that are already or have implemented testing. I mean, this is incredible. We've got Levine Cancer Center, part of Atrium Health in North Carolina, Bay State Health Cancer Center, I believe that's Florida, Cleveland Clinic, Dana Farber, Duke, Oxnard in Louisiana. They test all their patients, and St. Elizabeth Healthcare in Kentucky. And what those institutions are seeing is, they are seeing that 5% of the patients, like Dana Farber, for instance, implemented DPYD testing, and their numbers are backing up the other science that 5% of their patients are coming back DPD deficient. And then with that, they can then follow the Clinical Pharmacogenomics Implementation Consortium, otherwise known as CPIC. They give dosing guidelines. If this is your DPYD variant, this would be your dosing guideline. So, like, and they also give you some of the labs give you a metabolizer status, a number of 0 to 2. So 2 would be, your fully functioning DPYD gene. For me, I have a 1.0, so I'm only 50%. So CPIC says a 50% dose reduction. And that was on my Mayo Clinic, or my Mayo Labs report. Um, and then when I got my kids testing to make it easier, I used Color Health, and it was just, they signed up, they sent a kit to their house, they spit in the tube, sent the tube back, and in a couple weeks they had their result back. And I am a super fan of that company. They have a huge DPYD panel. I want to say 12 variants.
Mm-hmm. Mm-hmm. And your children undergoing the testing, were any of them concerned about the testing, or was it something they were extremely motivated to do? I'm guessing.
They were very motivated, to do it, especially being close to their grandmother and knowing how passionate I am about it. There are people, that are like, "Well, this is gonna be, my DNA is gonna be out there." But there are laws, and I don't know enough about that, but there's the GINA law or something to
Hmm.
protect that, your DNA cannot be, your whatever your findings are not being used against you. And I just, for me, what I've learned about DPYD and pharmacogenomics, this is going to be the future of healthcare, so we can get the right medicine to the right patient at the right dose. And that is exactly what DPYD testing is. You test, you find the variant or the dosing guideline. Maybe you're not going to have to reduce dose at all because they're a full metabolizer, and then that patient is getting the right amount of the drug for their body.
Right, which is what precision medicine is trying to tailor the treatment or the medication for people's DNA, for their
Right.
genetic makeup.
Yeah. And it's an economic situation too, where like at Oxner in Louisiana, they have seen by doing upfront DPYD testing, they've reduced their emergency room visits and they've reduced their hospital stays for patients with toxicity to this chemotherapy to zero.
Hmm.
So it's saving money, it's improving the quality of life for these cancer patients and saving lives.
Yeah. Yeah, and I think going back to Gina and some of the legalities, I would say, of genetic information, there's still some ins and outs in terms of employment, health insurance, life insurance. So my guess is that's probably why there's recommendations to offer the testing, but not saying that you have to force a patient to do the testing. But I also know that there's some places where they're like, if we have a patient who's getting ready to undergo 5FU, this is the case where we want to test them, because the benefits at this point probably outweigh the risks.
Yes, and the legal risks of an oncologist or a clinician not telling their patient about DPD deficiency, not discussing testing, giving them this medication, and then the patient's dying. Well, then they're at risk for a medical malpractice suit, and that is an issue as well, right? And so hospital administrators have a responsibility for their hospital to protect the clinicians as well. And one way they can do that is by putting it into processes, the workflow in a clinic, right? Like, oh,
Right.
you have to put something in a request for 5FU, and they can say, oh, we can't, you can't give that medicine unless you have the DPYD test results.
Hmm.
So that is a huge thing. And there was a lawsuit in Oregon where a widow sued Oregon Health Sciences University, after her husband passed away from capecitabine, and this was considered cleanup chemo, in her words. And so they settled, out of court just days before going to trial.
Hmm.
And I have to, that is not the only lawsuit that there was or will be. This needs to be standard of care to protect patients, and it will also protect clinicians and hospitals. And Mass General just started testing in January, and an oncologist there whose patient died, I have to think that oncologist is going to be forever changed. So it's hard on the family. Yes, it's horrific. It's a horrific way to die. It's also these clinicians that aren't aware of what this can do to a patient. It could be life altering for them as well.
Right. I mean, they're there trying to cure or slow the progression of cancer. So they're there to try to help the patient live and to not even be aware that there's something that they're under the impression that they're giving the appropriate treatment just
Right.
because there's that lack of awareness.
Right. Yeah. So, in my mind, hospitals have a responsibility also to be aware of this and put testing in place in the workflow that it makes it aware. Or, also we've seen in electronic health records, they have to click that, yes, I have counseled my patient on the risks of DPD deficiency and discussed testing. That's another way hospitals have done it if they are not going to require testing.
Okay, so there's a few different ways then that some of these places could implement programs, and it sounds like quite a few clinics have just said we're going to just go ahead and do this and start doing this, even if someone like NCCN hasn't come out and said this should be part of standard of care.
Yeah, I met Dr. John Strickler at the ASCO Gastrointestinal Symposium in January, along with two other advocates when we were exhibiting. And he gave a presentation about something else, and we went up and talked to him afterwards. And he's at Duke, and he says, "Oh yeah, we test all of our patients. It's standard of care." He says it's patient safety and it's in the labeling.
I'm curious, how has it been working in the patient advocacy space? Because you mentioned, working together with other advocates, but also still seeing cases where people have died due to toxicity. I don't know if you were an advocate or worked in the space prior to losing your mom, but how has it been working in the space? How do you continue to keep going and to keep pushing for change?
We created our website. What we really wanted is we wanted to get information to patients after diagnosis and before treatment. And sadly, our group grows because people aren't hearing about DPD deficiency until their loved one is in crisis and in the hospital. And that is just so heartbreaking. And it's like kind of like pulling the scab off and reliving our own loss as we're living the loss and supporting these patients. So that actually makes us pretty angry as advocates, that why aren't you listening, why aren't you changing the guidelines? And you actually my mom has passed away a lot longer than some of the new people in our group, and it, but it still brings you to tears, right? That especially for me, my mom was like, she was the glue, kept a lot of our family together, just like my rock. I still think of things I want to tell her. We have had a couple wonderful examples where somebody reached out to us and she did her own research and she knew what DPD deficiency was. She asked her community oncologist for a test, and she had also had a second opinion at
Hmm.
a NCCN member cancer center with an oncologist. And both of those oncologists said, "Oh," when she asked for a DPYD test, we don't do that in the United States. And she pulled up our website list that she had printed out. And she says, "Oh, yes, we do this testing in the United States. It's done here, here, and here." So with a lot of force, she was able to get her DPYD test. Turns out this woman in her 40s, married, two kids, she has the most common DPYD variant. If they had given her full dose,
Wow.
we think she thinks she would be dead.
And if it wasn't for her
Yes.
pushing,
And I can see, going in and you have this diagnosis, all this information comes out at you, plus you have all these emotions about cancer, having cancer, and then you ask about it and you trust your oncologist, right? That's my mom trusted her oncologist that she was making the right choice. She didn't even want to get a second opinion. And so we had to respect my mom's wishes at for that. And it can be intimidating to push, if you like this young woman that who pushed like that isn't always the case. But fortunately she pushed, and she's, I think, going through her second round of capecitabine right now at a 50% reduced dose, which is CPIC guidelines for her. And, she had a little bit of toxicity, could have been from the other medicine that's in her, the other chemo that's in her regimen. But she, hopefully, I don't know how many treatments. I think it'll be 6 months. And hopefully she's going to ring that bell and she's going to be a loud advocate.
And it sounds that the nonprofit's website was a great resource. So I wanted to make sure that we highlighted what the website was so that people know where to go find information.
Oh, yes. Test the number 4 and then dpd.org. So testfordpd.org.
And we'll put it in the show notes as well, because I think it is a very helpful resource, especially if this person was able to say, okay, here's where I can get it, or here's where it's available.
Yeah, and when she contacted us, we were also able to connect her to an oncologist who could give her some information or give her some suggestions to share with her oncologist because he tests all of his patients. So, and we do have quite a few oncologists that we can refer people to because none of us are medically trained, and also pharmacists. I mean, I really feel like at some of these cancer centers where DPYD testing is standard of care, the pharmacists have really got the ball rolling and pushed it. And like you, a genetic counselor, I mean, you're aware of the how our genes are different, and the pharmacists are aware of the pharmacokinetics, how that works, and can support the oncologist and push for it at institutions.
Yeah, and with cancer treatment, I mean, it's what they always call multidisciplinary. Like there's a whole team, right, of people with different backgrounds, different certifications, different training. And so the more awareness you can bring to each members of those teams, in addition to the patients, again, it just helps to have more than one person take a look and say, has this been done? Have we discussed DPD testing?
Right.
If there's one thing that you want people to take away from the conversation, or maybe one action item or call to action that you want people to walk away with from this podcast, what is the thing that you want them to remember?
Knowing your DPYD status before you start any chemotherapy treatment, for me, is asking all those questions. I don't know if I could say just one thing, but yes, test for DPD before 5-FU and capecitabine. For me, it's a no-brainer. It just seems like, we say oncologists first do no harm. If oncologists, those who are aware of what the risks are, treating without testing seems like it's not standing up to that oath, right? First do no
Mm-hmm.
harm, the Hippocratic oath. And patients being aware and sharing, as people that are hearing this, sharing it with your friends. I don't know what the statistic is, how many people will end up with cancer, but just letting somebody know. And I think the more I talk about it, the more other people hear, and then I get feedback like, oh my gosh, I'm so glad you told me that. I had my father-in-law tested or suggested, and thankfully he's not DPD deficient. And I'm just like, well, that's great, right? He wasn't,
Mm-hmm.
but at least there's that sense, a little bit of, okay, he's tested. And I think it also educates other people. Like, knowledge is power, and knowing this information is important.
Right. And unfortunately, I think many of us have friends or relatives who've had cancer. And as you said, it's not limited to just one cancer type. So I think that awareness and being able to let other people know, hey, if you've been diagnosed and are considering this chemotherapy.
Yeah, and I think with 5-FU being the mainstay chemotherapy for colorectal cancer, and with younger people, more and more younger people getting colorectal cancer, it's even more important for people to be aware and to share the knowledge.
Yeah, and Karen, I appreciate you being here to take the time to share not only the advocacy work that you and your group are doing, but also your personal story and why you're working on this. I think it's very important for people to hear about it, to learn about it, to be aware of DPD, DPYD, and its role in cancer treatment.
Yes, I agree. Thank you so much for having me.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening and join us next time.